Can you guys hear me okay? Um, my name is Hai Sung. I'm one of the attendings in the neurosurgery department, and my specialty is in epilepsy surgery, and I also do cerebral vascular surgery, treating aneurysms, AVMs, and I also treat carotid stenosis, both through the open approach, such as carotid endarterectomy and also carotid stenting. So today I'm going to talk about some of the classic trials we have had in the past to help us understand how to treat those lesions. As we know, stroke and carotid stenosis are common disease in U.S. Almost 800,000 strokes each year. Of those, 600,000 are new. The prevalence of asymptomatic moderate to severe carotid stenosis in older people older than 65 years old, it's about 5 to 9% depending on the study. So there's approximately 1.3 to 2.4 million people with this condition. And there are estimated 4.9 million people with symptomatic carotid stenosis. About 36% of those people has moderate to severe stenosis. So not all the symptomatic carotid stenosis had high-grade lesions. So there are some of the landmark trials I'm going to talk about. First, we'll start with the landmark trials compare the carotid endarterectomy with the medical management. And those, there are 3 trials I'm going to talk about. One is Nasida, then the second one is the European Carotid Surgery Trial, and the third one is the ACAS. So those trials are conducted in the early 1990s. And back then, the medical management consisted of aspirin, basically. So as later on we will discuss, now this is the initiative and the call to repeat those trials, because now the medical management has had many more choices, and the efficacy probably has increased dramatically compared to when we had just aspirin as the medical management. So Nasida is a trial conducted in the early 1990s. And so in this trial, the results showed the incidence of a perioperative stroke within 30 days is higher than the medical management alone. That means that if you take patient to undergo carotid endarterectomy, during the perioperative period within 30 days of the procedure, they will have a higher chance of having a stroke than the patient who haven't had surgery. But as the time goes on, in 2 years, the risk of ipsilateral stroke or stroke with death decreased significantly with carotid endarterectomy. For patients with 70 to 90% of stenosis. In the medical management group, the rate is about 26 to 32% for stroke or stroke-related death, and for the carotid endarterectomy, the risk decreased to 9% to 15.8%. The risk reduction for the patient with a lower grade stenosis who are symptomatic also decreased. The reduction is somewhat more moderate, between 6.5% to 10% in the lower grade stenosis, but this is still significant. So what this means is, if patient has a life expectancy greater than 2 years, if they have symptomatic carotid stenosis, they should undergo carotid endarterectomy. The surgery plus medical management is more superior in preventing the stroke and preventing the stroke-related death than medical management alone. The second trial is a European carotid surgery trial. So in this trial, patients with mild stenosis, so those are probably 25 to 50%, had little risk of ipsilateral ischemic stroke. And so the surgery has a very small benefit. And the benefit is outweighed by the surgical risk. At 30 days, the incidence of stroke or death was 75% in patients with a severe stenosis who underwent carotid endarterectomy. This is comparable for compared to the previous trials, which is also higher than the medical management. But again, at 3 years, the patient was treated with CEA has a significant reduction of the stroke risk. In the surgical group is about 2.8% versus about 17% with aspirin, and this is statistically significant. The reduction in stroke-related death is also significant in the carotid in the CEA group is about 12%, and in the medical management group it's 21%. What about for the asymptomatic patient with carotid stenosis? So this trial is the ACAS. The trial randomized about nearly 1,700 patients with greater than 60% stenosis to surgery versus aspirin. And those patients were followed up to almost to about 3 years. And in the surgical management group, the stroke risk during that follow-up period is about 5% versus 11% with the aspirin group. This is also statistically significant. In their subgroup analysis, that in this trial particularly, CEA was less effective in women, and probably due to a higher incidence of perioperative complications among women, about 3.6% versus 1.7% in men. What are the typical complications related to carotid endarterectomy? And the mortality is usually pretty low, and depending on the institutions, it's less than 5% to about 3%. The majority of death is due to cardiac event, and you will see this theme as we go on to some subsequent trials. Because of this, we pay good emphasis on preoperative screening for cardiac risk factor. And stroke is second most common cause for mortality, and the rate is between 0.25 to 3%. As we've seen in the 3 trials, the perioperative stroke risk increases with the surgical group to around 6% in all those the 3 trials. But if patient has a life expectancy greater than 2 to 3 years, then they receive the benefits of the surgical intervention. And because of those approaches, the cranial nerve injury is also a common complication. Hypoglossal is the most common one. That's the 12th nerve. And vagus nerve and recurrent laryngeal nerve and sometimes facial nerves are affected as well. The glossopharyngeal nerve usually are responsible to the cardiac and the blood pressure hyperdynamic during the surgery. And also the complication includes neck hematoma, infection, proctitis, and there's also a restenosis rate up to 20% for patients receive carotid endarterectomy during the follow-up. So based on those 3 trials in 2006, and the American Heart Association put out those recommendations for patients with either symptomatic or asymptomatic carotid stenosis. So if a patient is symptomatic and they have a high-grade stenosis, meaning 70 to 90% stenosis, CEA is recommended by a surgeon with a perioperative morbidity and mortality rate less than 6%. And for patients with a lower grade stenosis and symptomatic, CEA is also recommended if you take in consideration of a patient's life expectancy and their comorbidities, and make sure they can live long enough to receive the benefit of the surgery. For patients with asymptomatic stenosis, if they have a stenosis greater than 60%, CEA is also recommended. But in these cases, the requirement for the surgeon's skill is even higher. So you need to have less than 3% of perioperative surgical complications in order to provide benefit for those patients. So now we go on to talk about the trials compared to carotid endarterectomy to endovascular carotid stenting. So there are 5 trials I'm going to go through. And carotid stenting became increasingly popular in the 2000s, and also with the recent trials, I think has become more and more widely used. But we'll go through the results of those trials. So Sapphire is the first trial. So in this trial, they enrolled both symptomatic and asymptomatic patients. For patients who are symptomatic, if they have a greater than 50% stenosis, then they are enrolled. But for asymptomatic patients, they need to have a greater than 80% of stenosis in order to be enrolled. And this trial is basically to look for the question whether carotid stenting is better procedure for patients with high-risk features. So they preferentially enrolled patients has at least one of those following high-risk features. Either they have a significant heart disease, severe pulmonary disease, contralateral carotid occlusion, or previous major neck surgery or radiation, or patient with a recurrent stenosis after carotid endarterectomy. And finally, older patient with age greater than 80 years old. And they enrolled 334 patients in this trial. And this is some of the results. And the gist of the Sapphire result is the outcome is basically driven by the perioperative cardiac events. So the differences between stenting and endarterectomy in stroke is about the same, so 3.6% to 3.1%. But the rate of myocardial infarction is significantly lower in the stenting group, 2.4%, and versus 6.1%. As a result of that, it affected the death and the eventual outcome of the trial. The ipsilateral stroke in this trial also is lower in the stenting group, which is a little different than some of the results I'll talk about subsequently. Of course, with stenting, almost no chance you'll have a cranial nerve injury, but carotid endarterectomy, the rate is about 5%. So based on those results, the authors concluded the carotid stenting appear at least as safe or effective as the endarterectomy in treating carotid stenosis in this population. Again, the result is primarily driven by the perioperative cardiac events, which put the stenting as a more favorable approach among this group of patients. Some criticism arisen from this trial point towards the carotid. There was a bias in the patient being referred to the two different groups, with the carotid endarterectomy cohort had a higher risk stenosis group of patients that potentially explain why the stroke risk actually was higher in the endarterectomy group, because more risk stenotic patients received the open surgery. The second study is EVA3S. So this is, again, the hypothesis is the stenting is not inferior to endarterectomy in treating severe symptomatic carotid stenosis. In this, they did not preferentially recruit high-risk patients. So the trial is basically wanted to demonstrate those two approaches is equivalent. And this trial was stopped prematurely for the reason of safety and futility, when the relative increase in the 30-day risk of stroke and death for the stenting. There was a high risk of stroke with a stent-treated cohort. There was no significant difference was noted in this trial in the incidence of a myocardial infarction between the two cohorts. With a median follow-up to 3.5 years, the overall probability of stroke and death was lower in the carotid endarterectomy group, with a 6.2% versus the stenting group was 11%, and this was significant, statistically significant. The criticism arrived from this study. The major one was the stenting group. The operator had a lack of experience. They only had a requirement of 2 stent procedure before they were allowed enrolled in the as an operator for the trial. So this may explain why the stenting result was not as good as the endarterectomy group. And also in this particular trial, the embolic protection device was optional. So they did not always use the device that deployed distal to the stent to catch any kind of emboli dislodged from the manipulating of the stenosis. The next trial is SPACE. This is, again, another trial to demonstrate there's no inferiority between the carotid stenting versus carotid endarterectomy for severe symptomatic stenosis. And the incidence of the stroke in the or death in the perioperative period between those two cohorts were not different statistically. Neither was the cardiac events. So this is the first trial where the carotid stenting and the carotid endarterectomy seem to have the overall risk profile and the outcome profile as well. And again, in this trial, the embolic protection device was also optional, although again, this trial did not show any statistical significance in the primary outcomes between the two groups. Then the next trial is ICSS trial. Again, this trial is to compare the stenting versus endarterectomy. They enrolled a low-risk patient, unlike in the Sapphire trial. And here, the patient has to have 50% stenosis. More than 1,700 patients were enrolled. And in this trial, more than 70% of cases in the stenting, the embolic protection device was deployed. In the perioperative period, the incidence of a stroke is the same for the both groups, about 2%. But the incidence of fatal and non-disabling stroke was significantly higher in the carotid stenting group. The main safety endpoint, stroke, death, or procedural MI at the 4-month period, was 8.5 for the stenting and 5.2 for the carotid endarterectomy group. This is statistically significant. Again, this trial seemed to favor the carotid endarterectomy. The most recent trial is the CREST trial, where both symptomatic and asymptomatic patients were enrolled in the head-to-head trial between the stenting and the endarterectomy. For the screening, they use both the angiogram and the non-invasive imaging modality to screen the degree of stenosis. So by angiogram, greater than 50% of stenosis, and if patient is symptomatic, those patients are enrolled. But if you use a non-invasive imaging technique such as CTA or MRA, the degree of stenosis has to be greater than 70%. And for the asymptomatic patient, angiogram demonstrated stenosis has to be greater than 60%, and 70%, greater than 70% by ultrasound, greater than 80% by CTA or MRA. They enrolled more than 2,500 patients, and the symptomatic more than 1,300 patients, asymptomatic nearly 1,200 patients. And they had a rigorous lead-in phase for credentialing for the stenting. The operator has to have more than 12 cases a year with complication rate of less than 3% for asymptomatic patient, less than 5% for symptomatic patient. And also there's additional hands-on training if they felt the operator needed more experience. Distal protection, embolic protection device was deployed in all procedures for stenting. And they use the same equipment for all cases, AccuNet stenting and the AccuLink distal protection device. And for the medical management, all the patients were placed on aspirin and Plavix. And 97 patients were preloaded, and 88 patients received dual antiplatelets postoperatively. The primary endpoint for the study were any procedural stroke, MI, death, or post-procedural ipsilateral stroke up to 4 years. And actually, they had the follow-up now up to 10 years. And this was just published this year in 2016. The incidence of a primary endpoint at the mean follow-up at 2.5 when this was published, at that point there was no difference between the carotid stenting versus carotid endarterectomy. However, perioperative period, the incidence of stroke was higher for the stenting than the CEA in both symptomatic and asymptomatic patients. The MI was higher in the carotid endarterectomy group. So this is differences in perioperative complication rate between the stenting and the carotid endarterectomy in stroke and MI. This actually has become a significant consideration for patients being referred to each one of the procedures. They also did a subgroup analysis when separated the group into symptomatic and asymptomatic group. There's no difference in any endpoint between the stenting and the open procedure among those two. While the there is a relative increase of risk for the peri-procedural stroke, but the decrease in risk of MI in the carotid stenting group in the symptomatic patients. Again, this difference between the stroke and the MI in the stenting versus open procedure. They also performed the analysis among different age group. This is a graph that shows the hazardous ratio between the carotid stenting and the open endarterectomy for different age groups. The x-axis is the age, and if the ratio is 1, that means either the procedure is equivalent. And it turns out that when patient is younger, carotid stenting seems to be more favorable. And when the patient, the age reach about 70 or older, endarterectomy seems to be more favorable, which is a little counterintuitive because, as we mentioned earlier, carotid endarterectomy seems to have a higher rate of MI, and the stenting has a higher rate of perioperative stroke. But you would think maybe the older people tend to suffer more MI, but the overall outcome seems to say that the stenting is more favorable for younger people, and the open surgery is more favorable for older people. This may have something to do with stenting. The endothelial hyperplasia, the stenosis may be more prevalent because the younger patients has a maybe more active endothelium, or they have a longer time to develop stenosis. I'm not sure. Another question often come up with is the timing of the procedure. So if we have a patient that just suffered stroke from carotid stenosis come to the ED with a stroke, or they had a TIA symptoms, we did this screening that we find they have 70% of stenosis. When should we do the procedure? And many studies has shown that the earlier procedure is actually better than delayed procedure. And this is a recent meta-analysis that put out for answering this question, where they reviewed many studies. And this study demonstrated that the stenting and the carotid endarterectomy intervention is safe within 15 days of onset of the stroke or TIA symptoms. And it may even be safe for within 7 days. So if the patient gets referred to, gets evaluated for stroke and had an intervention or medical management for their stroke or TIA symptoms, and they should be referred to us for intervention in the same hospitalization. So there's no need for the patient to have to recover from the stroke before they go on to have an intervention. And actually, early intervention may prevent further symptoms or stroke for those patients. So as I mentioned earlier, that some of those trials, especially the trial where we compare the intervention with medical management, was conducted in the early 90s with the advent of new medications such as statins and different antiplatelet agents. The medical management potentially has increased its efficacy. So now this QUEST-2 trial where people are enrolling patients to compare two modality of endarterectomy, carotid revascularization with medical management. So the result probably won't come out in several years, but potentially this will also change our how we manage those patients. So with those results, what we always have to consider is how are we recommend the treatment for the patient with those conditions. I think we have to take in consideration the patient age, perioperative comorbidities. Gender seems to be an issue, and as some of the trials showed, the carotid endarterectomy potentially may carry higher perioperative risk for women. So maybe stenting for women with a high-grade stenosis may be more favorable, but we don't have any kind of trial data for that. And also, recurrent stenosis seems to be more favorable with stenting, and so is radiation-related stenosis. If someone had a neck tumor, they underwent neck radiation, developed carotid stenosis, those patients should be referred for stenting rather than endarterectomy. So that's it. If you have questions, I'll be happy to answer some of them. Go ahead.
Congratulations. It's a very important topic. I'd like to hear the comments from Dr. Sang about the topic, and is Ulu around? Hi. I think we're coming. We have the basic sciences here, and you need to discover something that prevents us from clogging those vessels. Any comments?
Well, it's a very good review about this important clinical trials. It's, all we need to know. Basically, from a previous clinical trials compared CAS and CA, stenting versus endarterectomy, up to now, most clinical trials, like the Dr. Sen said, favors to CA. But the CREST-2, now we kind of waiting for the outcome. So the first part, they compare the symptomatic CS versus the CA, and Dr. Sen also mentioned the perioperative stroke rate in the CS group is higher, 4.4, and in the CA group is lower, it's 2.3%. However, the preoperative MI, of course, is higher in the open group because you need anesthesia, general anesthesia. But at this moment, based on American Society for Vascular Surgery, we still recommend to do CEA as a first choice unless you are high risk for open surgery. High risk, two things, systemic high risk. You have recent stroke, recent MI or unstable angina, severe COPD, CHF. You had, any other concerns the patient cannot tolerate general anesthesia. Then you talk about, you can think about the, carotid artery stenting. Or patient has anatomic high risk, which means you had radiation to your neck, you had a neck dissection for thyroid cancer or some other neck tumors, and you had previous carotid surgery with cranial nerve injury already. On the other side, you're going to do surgery on this side. If you have a both recurrent nerve injury, then you cannot breathe, right? So that's another high risk. Or you have a tracheostomy with a stump still there, so it's contaminated area. But if you have this kind of problem, then you should think about the carotid stenting. That's current guidelines. But we're waiting for CREST 2, and they already have some data come out that even for asymptomatic patients, carotid stenting may be as good as CA. But at this moment, we have not changed our guidelines yet. CA is still preferred, and if high risk, we can do CS.
Thank you. Great response. I have a couple of questions. One is related to, what would you explain for the people that are not familiar about the protection devices that you use in class, in the carotid artery stenting? They may not know about how the technique is. If you could just say briefly what they are and what are currently used.
So the carotid stenting, what you do is you basically use the catheter that you go to patient groin. You deliver a device, stent, that basically will open up the stenosis at the carotid bifurcation. But as because this is an endovascular approach, you don't have direct access to the lesion, and you cannot stop the flow. So as you manipulate the stenosis, deploy the stent, the chances are you may dislodge some emboli that potentially will cause stroke and during the procedure. That has been all demonstrated by all the trials that the carotid stenting seems to have higher perioperative stroke rate, probably because of phenomena like that. So what people have come up with is, if you can deploy another device distal to the place you're placing the stent, that kind of looks like an umbrella that can catch all the debris that potentially being generated while you're deploying the stents, then using that device can lower the perioperative stroke risk. So that's what the endovascular protection device is. It's basically like a mesh umbrella deployed distal to the stents to catch all the debris while you're deploying the device.
Yeah. I have two more questions.
Yeah.
Yeah. Once the prevention of this, what do you think would be? These procedures are fine, but their procedures are fine after the fact. The patient is already sick, is already with problems. Is there any recommendation about early detection, prevention? What is the role of screening? What is the role of that? And the second question, that now that we have here the basic sciences, what tools do you have to help us to prevent, this thromboembolic events?
Are you talking about the stroke phenomenon in general, or talking about the stents?
We're talking is like in the Middle Ages. We are focusing in people that are already sick And they're already sick with anatomical and symptoms, you know? So we are trying to fix, we are repairmen. And the repair, we can paint it more or less the same, but it's never as good as it was. Is there any role of early detection, prevention, or something, or we still need to wait until someone is symptomatic, you know, to do something?
Well, I think it's probably has something to do relate to cost of early screening. I don't think that this has been any recommendation to screen the general public for carotid stenosis. But if someone had a stroke-like symptoms or stroke, they should be screened for carotid stenosis. And if someone who is symptomatic from carotid stenosis, I think they should be referred for intervention immediately. And I have a feeling, I don't know whether there's data out there, but I feel the carotid stenosis intervention is probably underutilized. Underutilized. I think maybe the neurologist or the and I think there's also still, that's why I put that slide in, that a lot of people still probably under the impression if someone had a stroke and they have a carotid stenosis, they probably should recover from their stroke before you refer them. That's totally not true. Actually, there's data that show the best timing is within 2 weeks. Then the benefit of the intervention decreases if it goes longer than 4 to 6 weeks. So there's no need to wait to refer those patients for us to do interventions. And we see it all the time. For some of those patients, if you wait, they being discharged to the rehab facility or they go home, they don't show up for follow-up, and we lose them. Because of socioeconomic reasons, some of them we lost them for follow-up. So I have a feeling, the carotid intervention is underutilized. And we could have prevented more strokes if we could catch those patients.
Yeah, to answer what you're kind of getting at, there's not really, as far as I know, any good biomarkers for that degree of stenosis. But what is kind of coming out in the vascular biology field is the idea that high shear flow through the vasculature at that point can cause the endothelial cells to release various things like microparticles that could be used as a biomarker for a stenosis somewhere. I wouldn't tell you where, but it may be able to give you an idea that there is a stenotic lesion so somewhere. And as far as tools to break up the emboli, I think it gets back to what Dr. Zhang was doing with some of his research with the normal blood clot. We have a lot of tools at hand, but with cholesterol emboli, right, how to break that up is not really very well known or very well studied at this point. And there's potential there for, if we can find out a nice way to do it.
And another important research I have seen is how to stratify the risk for lower degree of stenosis. So the plaque, they have a different risk profile. 30% stenosis in some patients could be very benign, but in some patients they could have a stroke, within 2 weeks. If they have a feature of ulcerative stroke, ulcerative plaque, and if people have done ultrasound or people have thought about maybe using endovascular approach to study the plaque and to see whether some of the plaques are more risky or more dangerous than some other plaques. So that's an active area of research as well.
So, a couple of comments about the filters. So you have different type of filters. You have a distal protection. Use, like Dr. Sen said, you use the umbrella. It's like a filter you put in there. Use some filter with a wire and you can go, some filter you can deploy it there without, you can remove the wire and recapture later. So that give you a chance to just use a wire for your stent. A different set, designs so you can use. Or you can use reverse the flow device, which means you use a balloon occluded your common carotid and external carotid, and then you got the flow from other side through the Willis circle, and get a backflow flush the flow down till you have little debris dislodged that won't go flushed into the brain. Sucked out from your catheter. So different devices you can use. That's for filters. For the timing issue, that's early days, we treat the patient with stroke. We usually wait for 5 to 6 weeks. That's like 5 years ago, we still follow that rules because if you do it earlier, you got a hyperfusion, you worry about, you convert this ischemic stroke to hemorrhagic stroke. But more recently, we got more and more data come out. That's not the truth. So even if you operate earlier, you don't have a significant increased hemorrhagic stroke, but a decreased recurrent TIA or stroke if you operate earlier. That's why we now following that. Most time we operate on patient or stent the patient within 2 weeks or even 10 days. Okay, that's another thing. For the clot, the plaque features, that's a good question. Some patient with very smooth, well stable, very stable clot, you can see from ultrasound or angiogram. But if your imaging study show that it's ulcerated, or even sometimes you see a little flooding thing, even if it's only probably 50% stenosis, and it will still go more aggressively to take care of that, to intervene. But the guidelines that if you have symptomatic carotid stenosis greater than 60%, you go ahead, do endarterectomy or stenting. Asymptomatic, before was 70%. Now we gradually increase the ratios because now we have better medications. That's a phase 2 clinical trials working on that to compare the patient with intervention versus medication. The point is like all of the landmark clinical trials were done like 15, 20 years ago. Back to that time, we didn't have good medications to stabilize the plaque, to do antiplatelets, that gave a bad block like that. So now we're waiting for the trials. Maybe in the future, for asymptomatic high-risk patient, you do a surgery or stenting, the outcome may not be good, may not be better than medical management. So that's possible. Now some places, like if you talk to Dr. Vieth, Dr. Vieth is very famous, probably #1 vascular surgeon now. They have a Vieth meeting, you probably already heard. He said, I don't do carotid anymore unless someone forced me to do. So if you don't do, I'm going to give it to somebody else. So that's what his opinion. But based on our clinical guidelines, we still treat asymptomatic patient greater, with stenosis greater than at least 70%. For patient with unstable ulcerated plaque or symptomatic with recurrent TIA or stroke, 50% is a cutoff number. If less than 50% symptomatic patient, the recommendation is to do 4-vessel angiogram to evaluate if the patient has an intracranial lesions or not. That generally speaking, less than 50%, no matter what, we recommend to treat medically. That's basically it. You have a question?
So it seems like both the stent angioplasty and the endarterectomy both have pretty severe denudation of the endothelium, and ultimately that's what would cause the restenosis or the thrombotic events. With the current drug-eluting stents that are being developed that help to reduce proliferation of the smooth muscle cells while promoting re-endothelialization. It seems like that would be the reason why you might see more benefits to the stent versus the endarterectomy. Are there any interventions or postoperative drug treatments that help to prevent, to promote re-endothelialization or to prevent proliferation of the smooth muscle cells?
Not in the clinical arena. I don't know whether there's any clinical trial. Right now, the patient who received the carotid stenting, they place an aspirin and Plavix. And so that's basically to prevent thromboembolic event. But I don't think we use any medication to somehow alter the endothelialization pathway. Not at this moment. Not to mention there's any trials.
You could inject something like endothelial colony forming cells or endothelial progenitor cells, but the problem is that the drug-eluting stents are going to really affect those cells that are trying to elute, to target that site. Whereas they may be more beneficial in something like the endarterectomy that doesn't have that drug there to locally block cell growth.
Well, a lot of clinical trials is doing drug-loading stent and drug-loading balloon for lower extremities. To my knowledge, I don't know any ongoing clinical trials, investigating the drug-loading stent for carotid stenosis. So for carotid, probably 99% is from atherosclerosis, some from radiations or tracheostomy vasculitis. Very rare. Recurrent stenosis occurred probably 10 to 15% of patients with stenosis. If that happened within 1.5 years, that's most likely from hyperplasia, and that's what we try to prevent. But after that, it's just recurrent from atherosclerosis. So you use a drug-loading stent or balloon, probably won't help a whole lot because it's not, hyperplasia stuff. But it's still small numbers of patients. They do have a recurrent stenosis from hyperplasia, but I don't know anybody is doing that with a drug-loading balloon or stent at this point.
In the peripheral world,
Sorry?
drug-eluting balloon and stent is a big controversy always. You go to Europe and they'll show you 5 trials of drug-eluting balloons and then they'll compare it to drug-eluting stents, and they are all over the place in the peripheral world. The other thing is to realize is the peripheral system is different from the central nervous system. They are two different systems with two different resistance. So what works in the periphery might not work in the central nervous system. And the peripheral system, you talk to people who are using both, and there are people who really swear by the drug-eluting balloons, and they have studies showing that drug-eluting stents are not good, and the other side there are people who use drug-eluting stents and they do not like the balloons. So it's...
Yeah, drug-loading balloon has a problem, okay? Drug-loading balloon can cause distal embolization. The medication is kind of put on top of the balloons. And when you touch the wall, the whole point is like the layer of medication kind of stuck to the wall. But sometimes they got flushed distally to the lower leg, cause distal embolization. Probably it's not a big deal for your lower extremity, but if you have that flushed into your brain, you're gonna have a stroke. That's probably why people kind of very anxious, very careful if you want to do a drug-loading balloon for that. So if you have a little piece of the medication that flushed into your brain, you probably, even if you don't have a big stroke, like you cannot move, but you have a minor stroke, you cannot speak, you cannot talk, you lost your memory, stuff like that. So you got to be careful.
And the drug-eluting stents have still problems with delivery systems. So people who have used drug-eluting stents from Cook have realized that the delivery system is very, very stiff. They actually come up with a new delivery system now, but still the delivery systems are still okay for the peripheral world. I don't think you are ready to try the delivery system in the carotid. There's a lot of resistance in putting those drug-eluting stents.
Those issues are important technically, and that's why the reverse flow, from the point of view philosophically,
Yeah.
it would be the safest.
Right.
Avoiding the reverse flow. Would you mind telling you talk a little bit about?
But sometimes, that the medication stuck in there, it may not fall off immediately. So once you pull out your filter, and then you got it flushed, so that's already, the study, when they did a clinical trial for lower extremity, they already showed that the patient with drug loading alone have a more ischemic. So you have to give a patient good anticoagulation for that. So, like I said, for lower extremity, probably it's not a big deal. You got you got a little glucose and give a anticoagulation, the patient totally recovered. But if you got it into the brain, your brain tissue cannot tolerate that long to have a collateral develop. The cells dead. So that's probably I don't know. In the future, maybe with advanced techniques and medications, it could be a.
Do you use reverse flow here?
Not in the carotid.
Yeah. Actually, the technique was developed for the carotid, the reverse flow.
We have not used it. And then another feature of restenosis between the carotid stenting and the carotid endarterectomy is the restenosis for carotid endarterectomy is much easier to treat than the restenosis from the carotid stenting. Because the carotid restenosis of the endarterectomy, you can either redo the endarterectomy or you can even have another stent, have a stent placed. But if they already have a stent, then they have an intimal hyperplasia, then they probably won't be a candidate for carotid endarterectomy because the stent being there makes the surgery almost impossible.
And that, intimal hyperplasia is an issue probably that you can comment 1 second because may address also your question about revitalization of the lesions. When the endothelium started repairing, does not stop. That's why they have these stents that with drug-eluting stents that prevent that excessive, proliferation that caused also by itself stenosis.
Well, for restenosis, the majority of the cell type in the neointimal thickening is going to be smooth muscle derived. And so you really want the endothelium to be there because that's going to prevent the hyperplasia or that proliferative response that you get from the smooth muscle cells. So the trick with the drug-eluting stents is how do you prevent proliferation of the smooth muscle cells but promote re-endothelialization to protect the smooth muscle lining from shear forces that you would see with blood flow. And so one of the challenges with a drug-eluting stent is that it works until the drug wears off, and then you have restenosis again. Or I think at this point too, Kathy Martin from Yale, she came and talked at the cardiovascular seminar maybe about a month ago, was talking about how it might not necessarily be the drug, but also the design of the stent, because the design of the stent may also help to prevent as much damage to the endothelium or denudation. So but ultimately, re-endothelialization, I think, is kind of what people are trying to look at.
So basically, use the endothelial cell to cover the smooth muscle. The sooner you do that,
Yes.
the less likely to have the internal hyperplasia.
Right, and so I would imagine with something like an endarterectomy where you're just yanking out the whole interior lining, and you would have a lot of problems.
Well, great. Well, thank you very much.